Is that clear?
Yes, please. Thank you.
Okay, thank you to join us in this education program in pediatric emergency medicine. In this session, we're going to talk about some cases about pediatric emergency radiology. And as you know, this topic is a huge topic regarding the trauma and non-traumatic conditions for pediatric radiology. And that's why we're going to just focus for the traumatic pediatric emergency radiology, which may face it in your shift and your clinical work. So the objectives, as I mentioned, we're going to focus for just traumatic pediatric cases. We're going to discuss the normal diagnostic imaging for such cases, and we will mention some tips to detect some abnormalities when you see this kind of films, in addition to some brief management for selected cases. So we're going to start with the case one. So this is a 9-year-old boy fell down with outstretched left arm, presented to emergency department with pain on his left forearm and elbow. So when you examine him, there was a tenderness over the proximal left forearm. The patient was unable to flex, extend supine, or pronate his elbow. And neurovascular was intact. And this is the lateral view of the X-ray for that patient. So before just make a diagnosis for such case, we're gonna just start with the normal elbow lines, and this is very important to diagnose such case. So the most important is the two lines, the anterior humeral line and the radial capitular line. So as you see here, this is the anterior humeral line. You can draw a line at the anterior surface of the humerus, which transect the capitulum. This is the capitulum. So it should be in one third of the capitulum. This is the anterior humeral line. This is the normal line. The second one is the radiocapitular line, which is this one. This is the anterior humeral line, and this is the radiocapitular line. Again, you can draw a line from the radius, which bisects the capitulum. This is one third, the anterior humeral line of the capitulum, while the radiocapitular line from the radius, mid of the radius, which intersect the middle of the capitulum. This is very important when you see such case. Okay, so this is again, this is a view shows the both lines, anterior capitular line, anterior humeral line and radiocapitular line, as you see here, this one and that one. These are the normal lines. Okay, so we're gonna move to our case. As you see, the radiocapitular line is disrupted. So this is the capitulum and this is the radius. Of course, this is a very obvious fracture, very obvious deformity, but sometimes you can see kind of subtle injury, minimal injury. It's difficult to detect. So it's very important, those lines. So this is what we called Monteggia fracture. Monteggia fracture, it's a proximal fracture of the ulna and disruption of the radiocapitular line. So the radius, the head of the radius is dislocated. So this is what we call Monteggia fracture. So the mechanism of that fracture, usually direct blow to the forearm. There is a chance of injury of the radial nerve by 17%. And as you know, the treatment for such case is open reduction, internal fixation. So we're going to move to the case 2. Again, this is a 7-year-old boy fell down on the outstretched left forearm, presented to you complaining of pain and swelling of the elbow. As you see, there is kind of deformity here. There is maybe a kind of, you see on the distal part of the humerus, but before, and there is kind of maybe edema here. Let's just talk about the some tricks here. So this supracondylar fracture, as you know, what's the abnormality here? The supracondylar fracture. Mainly, I'm gonna focus on the X-rays or the radiological studies more than the treatment and the presentation of the patient. Okay, so now what you're gonna see for the supracondylar fracture when you do X-rays. The type of X-rays, you need two views, as you know, AP and lateral X-ray of the elbow, and look for posterior fat pad sign, and the second one to diagnose supracondylar fracture, displacement of the anterior humeral line, and the alternation of Baumann's angle, and we're gonna talk about it in a second. So this is what I'm meaning the posterior fat pad sign. So normally you don't see any lucency here at the back of the humerus because there is a very strong fascia. It's attached to the posterior surface of the humerus. So normally there is no any lucency. Never ever you see lucency at the back of the humerus, unless there is kind of injury. And if there is kind of injury here, minimal is an injury, we call it occult injury. So something hiding here, okay? So the message is never ever you see any lucency at the back of the humerus for the kids, okay? So this is what we call posterior fat pad sign. It's very, very important to know about it. So as I mentioned, the posterior. What about the anterior? Anterior, normally you can see small amount. I repeat it, as a small amount of fluids or lucency in front of the humerus. And this is sometimes normal variation for the adults and pediatrics as well. So the most important is the posterior fat pad sign. If you see anteriorly and there is no kind of fracture, expect it will be normal. But once you see it posteriorly, as I mentioned before, this is abnormal, definitely abnormal. Okay, so second feature in supracondylar fracture, for the supracondylar fracture for an X-ray, displacement of the anterior humeral line. As we mentioned, the anterior humeral line is supposed to bisect the capitulum. But the capitulum actually it's displaced posteriorly, and there is two types of supracondylar fracture, the flexion and extension type. So this one, the capitulum is displaced posteriorly. So this one's supposed to be here, but it goes back. So the anterior humeral line is displaced, disrupted. That means there is some kind of problems here. Okay, so the third radiological features for supracondylar fracture is distortion of the Baumann angles. So let's talk about the normal Baumann angle, how to draw it, how to see it on the X-ray. So what you need, just draw a line at the middle of the humerus, anterior humerus here, as you see. This is the first line, the yellow one. The second line, you can draw it actually between or above the lateral condyle. So this is the lateral condyle. This is ossification of the lateral condyle. So it will be in between here, above the epiphysis of the lateral condyle here. So this is the angle. So forget this one, the line here. So what you need, just this, the blue one and the yellow one. So just measure the angle here. The angle here is supposed to be not more than 75 and not less than 70 degree here. It's very important. Again here, and we show it in the in this view. Again, this is the first line, and this is the second line, as we mentioned, to the superior of the surface of the lateral condyle. It's very, very important. Okay, so now this is the abnormal. As you see, there is a fracture here for supracondylar fracture condyle, and there is alteration of common angles. So if you draw the two lines, this is the yellow one, and this is the red one. This is the red one. This is the yellow one. If you measure this angle, it will be more than 75. So this is abnormal. Okay, good. So now, so case 3. Another child falls into outstretched arm. As you see, there is kind of abnormality here, and this is what we called buccal fracture or torsal fracture. This is one of the most common fracture in children. Buccal fracture or torsal fracture secondary to kind of compression to the bone itself. The long axis of the bone, it will be compressed, and that's why it will give you this kind of fracture or torsal fracture. So the key here, the cortex of the bone is intact. The cortex of the bone is intact. This is very, very important. Okay, so now buccal fracture, it's only one side of the bone is affected. This is the most common, but sometimes affecting both sides. But again, the cortex of the bone is intact. This is very important to diagnose buccal fracture. Okay, and the most common site is the radius, usually forearm, but around the wrist. But the most common site is the radius bone. Okay, so let's go to the next case. It's a 5-year-old child who fell down from the bike, and this is his X-rays, the AP X-ray of the forearm. So there is kind of something broken here and here, and if you focus more and more, there is disruption of the cortex or periosteum here, and the opposite side is intact. This is disrupted here, and the opposite side is intact, as you see here. Okay, this is what we call Greenstick fracture. So again, if you look to the white arrow here and there, the bone here is intact, while the black arrow shows the other side is broken. So this one is broken, this one is contact, this side is broken, the other side of the same bone is intact, again here and there. And this is typical for Greenstick fracture. Okay, so how to differentiate between buccal and Greenstick? This slide is very, very important, please. So the buccal fracture location usually in metaphysis of the bone, while Greenstick diaphysis of the bone. The cortex, as I mentioned, it will be intact in the buccal fracture, while in Greenstick it will be disrupted. The periosteum to be disrupted in Greenstick, and that's why how to differentiate between the buccal and Greenstick fracture. Okay, let's move to the case 5. So a 12-year-old boy collided with another boy while playing a football. This patient had history of right knee pain for 2 months, intermittent, on and off. So the patient actually denies any hip or ankle or foot pain. The patient was obese. When you examine him, you saw him, he's lying on a stretcher. The hip was flexed, abducted, and external rotated. And there was a pain with any movement of the hip. Okay, so is there any thought? Okay, so now the differential diagnosis for such patient, as we mentioned, this patient is at 12 years. So it could be toxic synovitis, septic arthritis, kind of Peyer's disease, or Charter disease, or SCAFI. So let's just start one by one. So toxic synovitis is unlikely. It's unlikely, which is a traumatic patient usually presented with upper respiratory tract infection, UTI, febrile, and it's unlikely to be this kind of case. Septic arthritis, again, Patient should be febrile, not related to trauma. When you do some kind of blood work, you're gonna see the ESR, CRP high, so which is unlikely. So Bert disease, again, because Bert disease affecting the younger than this age, 12. Shelter disease is unlikely because shelter disease will affect around the patella of the knee. So what about the SCAFI? Again, SCAFI, the slipped capital femoral epiphysis. This is most likely of the diagnosis. So the X-ray findings for SCAFI is physical plate widening, as you see here. It's widening of the physical plate comparing to the right one, as you see here. So it's widening of the physical plate. Klein line, we're going to talk about it in a second. So epiphysis moves inferior and posterior. As you see here, this is the epiphyseal plate, and this is physical plate. This is the epiphyseal part. It's supposed to be here. So it moves down, okay? So inferior and posterior, anterior and the 12 go inferior and posterior here. And the last one is disruption of the Shenton line. We'll talk about in a second. So this is what we call the Klein line. This is called Klein line. So this is the normal. So if you draw a line at the anterior surface or superior surface of the femoral neck. So this is the femoral neck, and this is the anterior surface or superior surface of the anterior neck. It is a must to intersect of the epiphyseal. This is the epiphyseal plate. So this is the line. So as you see, this is the part of epiphyseal. So this line, it's intersect of the epiphyseal. This is the normal. This is normal. But if you see, this is the abnormal. If you see the line here, if you draw a line at the superior surface of the femoral neck, the epiphyseal here, it goes down, and that's why there is any intersection. So this line will not touch the epiphyseal. This is, I think it's clear. Comparing to the right one, this is the normal, this is abnormal. This is the normal one. You see, this is the line. It's intersect of the epiphyseal plate, as you see here. It's very, very important. Okay. So let's move the other one. This is again, this is the right one. You see, if you draw you draw a line here, it will not intersect the epiphyseal. While here, it will intersect the epiphyseal, as you see here. So this one, okay? So again, this is the lines, column lines. Again here, this is normal, abnormal. Normal and abnormal. Okay, so the most important here for SCAFI is affecting the male more than female. Affecting usually the patients are obese, and affecting 40%. 40% it will be bilateral. The management is again it needs surgery. So as you see here, this is the screw which fixing the epiphyseal plate here. Salter-Harris classification is very important to know about it, especially for physical injury. We go just quickly here, as you know, this is the just abbreviation for the Salter-Harris or the physical injury. So if there is injury in the same physical plate, will be type 1, type 2 it will be above the physical plate, type 3 it will be lower, type 4 it will be above or through, it will be affecting the physical plate, epiphyseal plate, physeal plate, and the metaphysis. It will be through all over the this part. The type 5, it will be just compression, so narrowing of the physeal plate. So if you compare this one, the normal one, this one, it's compression of the physeal plate. Okay, let's move to case 6. So this is 12-year-old child who fell down. He came to you to emergency department complaining of or unable to walk. When you examine him, there was a tenderness on the proximal part of the 5th metatarsal bone. So as you see here, there is kind of abnormality here. But before we talk about this one, let's talk about the normal 5th metatarsal bone for kids. So this is the normal one. So if you see this one, this is normal. This is just ossification or apophysis of the base of the 5th metatarsal bone. This is just ossification. This is normal. Again, it's normal. So don't confuse with the fracture. The previous one, it was Jones fracture. Jones fracture, I brought it here, it's very, very important because you have to differentiate between Jones fracture and Pseudo Jones fracture because it's different management. It's different management, it's very important to know about it. And it's very common, not the Jones fracture, but the Pseudo Jones fracture. But once you see the Jones fracture, it's very, very important here for management-wise. So Pseudo Jones fracture, it's a fracture here between the junction between the metaphysis and diaphysis. So this is the diaphysis, metaphysis, there's a fracture here. So as I mentioned here, the fracture between the junction between the metaphyseal junction of the base of the metatarsal bone. Also again here. The treatment is surgery. This is the difference, the main difference to know, and you should know about to differentiate between the Pseudo Jones and Jones fracture. So the surgery, it's preferred here for Jones fracture. Okay, so let's go for the case 7. Again, same or another patient presented to you unable to walk. When you did X-ray for him, there is kind of abnormality here. And we know this is the normal from abnormal. So what about this one? This is what we call Pseudo Jones. Pseudo Jones, it's avulsion of fracture of the tuberosity here. It's an avulsion fracture due to the contraction of the perineus muscle. So it will avulse this part here, which causing the fracture of the bone. So it's away from the metaphysis. It's here just around the tuberosity of the bone, and this is what we call Pseudo Jones fracture. And this is the most common, more than Jones fracture. Okay, again, this is Pseudo Jones. Again, this is the normal, as you mentioned before. This is just ossification of the 5th metatarsal bone, and this is the fracture here. If it is Jones fracture, it will be here, or maybe here. So something here. This is Pseudo Jones. This is Pseudo Jones. This is Jones, and it's difference in treatment. The treatment for Pseudo Jones is walking cast, just walking cast, and this is very important to differentiate between Jones and Pseudo Jones fracture. This patient just back slap or walking cast and send him home, give him follow-up with the orthopedic trauma clinic or whatever. But that one, no, you need to refer the patient for orthopedic or possible surgery. Again, this is Jones, this is Pseudo Jones, and this is the normal. This is the normal, Pseudo Jones, and Jones. Please, you need to know this is very important. Okay, so let's go to the case 8. So this is another 1-year-old fell down, then he refused to walk. And when you examine him, there was no obvious deformity. It's actually, you see it a lot for such injury in this age. When you do X-ray, you don't see anything. But the patient, the kid actually, he is not able to walk. He's refusing. He's just elevating. When you hold him on his feet, he actually raise the affected one. So this is think about what we call it Toddler fracture. Toddler fracture. It's difficult. A difficult diagnosis, especially in acute case. But when you focus, when you are lucky, you're gonna see the abnormality. So toddler fracture is a tibial shaft fracture. It's one of the most common fractures for children for the tibia. Typically occur between 9 months and 3 years. 9 months and 3 years. Okay, the boy or the kid actually he will refuse to walk on his affected limb. And as I mentioned, it's very difficult. It's not that very difficult, but it's difficult to diagnose such condition. Again, if you focus here, there is kind of lucency here, and this is what's called toddler fracture. Okay, there is lucency of the distal part of the tibia. Here, it's very obvious. Again, here it's I don't know if you can see it, but there is kind of a hairy line lucency here in the distal part of the tibia. Again here, just focus and just look and compare between your exam and the site of the site of exam compared to the X-ray here. So it's very important. Again, there was no obvious injury here, but when you repeat the X-ray after 10 days, there is kind of a periosteal reaction here, as you see, what we call it sclerotic reaction or sclerotic line, the distal part of the tibia. This is after 10 days, and this is once the boy or the kid actually fell down. Okay. Let's move to case 9. Again, a 10-year-old child fall down in his knee. Any thought? So this is the distal part of the femur, this is the patella, and this is the tibia, fibula. If you focus, you're gonna see something here. This is what's called tibial eminence fracture. It's not that common, but you need to know about it. It's very important, and you have to have focus on the spine or plateau of the tibia. So this is fracture, what's called tibial eminence fracture. Okay. So what is the tibial eminence fracture? It's affecting ages 8 to 14 years. The mechanism is rapid deceleration or hyperextension of the knee, and usually associated with another injury affecting the ligaments, like meniscal injury, affecting the collateral ligament of the knees as well. So it's very important to focus when you look for knee X-ray. This is what we call it tibial eminence fracture, this one. Okay. So the treatment is conservative and sometimes need surgery. Again, this CT scan shows the tibial eminence fracture. As you see, this is the avulsion of the tibial spine by CT scan. Okay, so let's go to the last case, I think, case 10. This is a 12-year-old child, post-MVA. You decided to do CT scan for him. The patient actually, he was sick and GCS is low. You intubate the patient already and you send the patient to CT scan, and CT scan shows this one. So what you see here, yes, there's a bleed. So this is typical for subarachnoid hemorrhage. And why I brought these films? because I want to show you the clinical, CT scan findings for subarachnoid hemorrhage. You can see blood where in the circle of Willis. So here, circle of Willis. The circle of Willis is the blood supply for the brain. So we're gonna see a blood with the territory of the circle of Willis, as you see here, here, and there. Okay, so the affecting the all the supplies of the circle of Willis, or the territories of circle of Willis. The second thing is the blood in the cisterns. As you know, there is multiple cisterns in the brain, but this view shows the supracellular cistern. It's filled by blood. Here, supracellular cistern is filled by blood. And the third feature for subarachnoid hemorrhage in CT scan, you're going to see blood again in the fissures. As you see, this is the fissures here and here. So it will be filled by blood. Again, this is another patient who presented with the open skull fracture. As you see, there is a pneumocephaly here. So that means there is air in inside the skull. So this is indicate there is open skull fracture, or there is another cause, but this is the view it shows. So there is a pneumocephaly here. There's again there is a blood, subarachnoid hemorrhage, blood in the fissure and the supracellular cistern and the fissures. And this is again the findings in CT scan for subarachnoid hemorrhage. Three things. Please look for the blood in the three things: circle of Willis, cisterns, and fissures. Thank you.
Thank you, Dr. Abdullah. Jazakallah khair. Thank you. Very, very impressive lecture. Very impressive. And we always forget those lines and angles. And I have three questions for you quickly, Dr. Abdullah. If you can kindly go back to case number 6, Dr. Abdullah. Case number 6, it's really badly needed. أعتقد it was the Jones and the Pseudo Jones.
Yes,
please.
sure.
I'm not sure. أعتقد case number 6.
Case number 6. Yes.
Exactly. I think Dr. Muhammad Abdul Rauf is asking for these questions, regarding the management, for the Jones, really. Is there any rule for back slab here for this patient? Yes. Or it's always the surgery? Maybe that's, if you can highlight, please.
Yeah, sure. So as I mentioned, the Jones is more dangerous about comparing to Pseudo Jones. Let me just go to the slide here. Okay, again. So this is the Jones fracture. This is Pseudo Jones. This is the normal. Forget this one. So Pseudo Jones and Jones. The problem with the Jones fracture, it will be very difficult to heal. So the healing, it will be very difficult, and that's why they prefer to do surgery, screwing of the nailing of the fifth metatarsal bone. So the most of the orthopedic surgeon, they prefer to do surgery for Pseudo Jones, while for the Jones. While the Pseudo Jones, the treatment is just immobilization by casting, by walking cast. Again, Jones, it's very difficult to heal. That's why they need surgery. Pseudo Jones, usually conservative treatment, and they heal very well within 4 to 6 weeks.
Yeah, very good. Thank you. Thank you very much. I think in adults also we have the same problem. Sometimes we face some patients with non-healing problem, especially when they refuse surgery. Dr. Ahmed Al-Mtairi is asking about the supracondylar fracture. Do you use arm sling or use another form of a back slab or something?
If it is type 1, you can just use the back slab actually initially, because you need just immobilize the joints because due to the tenderness. And once there is significant swelling, I don't prefer actually to do full cast, because this will cause more edema and may cause a complication for the kid. So back slab is enough. Back slab is enough. and you can refer the patient to orthopedic clinic later on.
One more question, Dr. Abdullah, from Dr. Haifa. She's asking about the toddler fracture. You know, sometimes those cases can be difficult and they can be missed. Will you consider, for example, other imaging? What will you do if you don't see the fracture on regular X-ray?
I prefer once you don't see the fracture. As I mentioned, it's difficult diagnosis sometimes. Once the fracture is not that strong. So minimal fracture, it will not appear for such cases. So I prefer actually just once you are in the clinical work or clinical shift, just ask one of your colleagues, just look again and try to use the magnifier as well. It's very helpful. If you cannot see any fractures and you think there is kind of toddler fracture, I'm just gonna do a back slab for the kit and send the patient for orthopedic clinic to be seen by 48 hours. They're gonna repeat the X-ray. Hopefully they're gonna see something. But once you think toddler fracture, you don't see any radiological findings, you can do back slab. Back slab, immobilize the joint. It is a benign thing. Yeah, it will not affect the movement, and it will not affect the boy actually. So just back slab, send the patient to orthopedic clinic with follow-up.
MashaAllah, thank you very much. Jazakallah, thank you very much, Dr. Abdullah Bahmaid. Very impressive lecture, and inshallah we will be glad, inshallah, to have you again in the future with us. We will move, dear viewers, we will move to the last lecture. Dr. Nasser, are you online, please, if you don't mind?
Dr. Tawfiq, assalamu alaikum.
Alaikum salam. Yes, then can you upload your slide, please, Dr. Nasser, if you don't mind? Share a screen from your part. Thank you, Dr. Abdullah. Thank you very much. And we'll move to Dr. Nasser Al-Isa, gentlemen, for the persistently crying child lecture. Difficult case. Let's listen to Dr. Nasser's advice about it. Is your PowerPoint open, Dr. Nasser? Just share the screen. Is it open in your computer? Just open your PowerPoint, my friend, and share your screen. Is it okay? I think it's coming now, Dr. Nasser. Great, wonderful. Just go to the full screen. MashaAllah, tabarakallah, it's working very well.
Inshallah. Okay.
Just for the first one is the view, yes.
How is it now?
Yes, it's good.
Is it okay now?
Yeah, it is okay.
Okay, Bismillah ar-Rahman ar-Rahim.